So again, my name is Lori Green. I'm the program director here. We're going to start you out this morning with some exciting information on imaging fundamentals. It's always everybody's favorite topic. I'm going to try to make it as painless as possible, and we're only going to talk about the key basic points that you really need to know to get started in performing ultrasound examinations, no matter what type of ultrasound that you're performing. You really need to understand some of these key points to be able to effectively scan as well as optimize your image controls appropriately. So what we're primarily going to be discussing this morning is to discuss the interaction of sound with soft tissue and other mediums, how that happens, to demonstrate the relationship between the system controls and image quality, and also to go over some of the most frequently seen imaging artifacts that you need to be aware of so that you don't mistake them for pathology. So what we're going to talk about here is just the primary contributing factors to obtaining a good quality image. And so when we kind of narrow that down and we look at the key things that really affect our ability to obtain a good quality diagnostic image, it boils down to transducer selection as well as frequency, understanding how to optimize the system controls that we refer to as equipment knowledge. And then, of course, as with anything new that you're learning, you're not going to be an expert after a couple days, but you'll have the basic foundation to be able to go back and start performing these examinations, and over time is when you gain your expertise. So I call that the friends and family plan. They don't have to be real patients for you to practice scanning. Friends, family, co-workers, anybody you can find to scan, that counts as an examination. And then it's also important to realize that everybody has a different body habitus, and some people are going to be easier to scan than others. Some people are going to have had previous surgery or other things that impact the ability to scan them. And that over time, once you gain your proficiency, you're going to come to recognize really quickly who's going to be easy to scan, who's not, and whether you're going to be able to position the patient differently or manipulate the transducer differently to be able to overcome some of those imaging challenges. And that comes with experience. So when maybe you're doing a quick cardiac exam, a focused cardiac exam, you'll know right away whether you're going to be able to get the beautiful textbook views or you're going to have to settle for something that's maybe less optimum image, but you can still get your diagnosis. So those are things that come with experience, and just recognize that there's some people that you get good images on and some that you don't. So in order to understand the key components to being able to obtain a good quality image, the first thing we have to know is what is ultrasound. And simply, ultrasound is a reflection of energy off of tissues. We utilize high-frequency sound waves that are above the audible range, which is greater than 20 kilohertz or 20,000 hertz. And those sound waves are going to be transmitted into the body, and they move through the body in regions of high and low pressure, which we'll discuss a little bit later. The key thing is that sound waves require a medium to travel through. So sound does not travel well through air-filled structures, such as the lung and the bowel. So what we typically see is that we get either a fuzzy image or we might get a black shadow or so forth that obstructs our ability to effectively see the organs that lie either adjacent to or underneath that particular air-filled structure. So when we look at how the sound waves are transmitted, we have our ultrasound system, and within the ultrasound system is a device called a pulsar that basically generates an electrical voltage that travels out and energizes or interacts with the thin layer of material that's housed within the ultrasound probe, and that little thin layer of material is actually the transducer. When the electrical voltage interacts with the transducer, it causes it to vibrate and deform. Deformation of the element creates a sound wave that then travels out into the body tissues and organs. We always get a little bit of refraction where the sound wave goes off in different directions, but our goal is to get the majority of that sound wave to return back to the transducer. And when it does so, it's converted back into a radio frequency signal, goes through the system's processing, and then is displayed on the monitor for you to evaluate. Now that whole series of events is basically just converting electrical energy into mechanical energy, that is a sound wave, and then converting the sound wave back into electrical energy for you to evaluate. Whether we're doing Doppler spectral Doppler, color Doppler, imaging, M mode, sound, it's all sound waves and they're all generated in the same manner. So an important part of being able to obtain a good quality image is selecting the appropriate type of transducer. I refer to the transducers as a workhorse. Doesn't matter what size system or how expensive it is, if you're not scanning with the appropriate transducer, you're not going to be able to get the images that you desire. The transducers serve two functions, one to transmit the signal and the other is to receive the signal. And we refer to that as a pulsed echo technique. And the reason that we call it a pulsed echo technique is that when we energize those crystals, we send out the signal and we can't send another signal until the first one comes back. That's what gives us our range resolution. So we know the system measures the time it takes for that sound wave to travel out to the target and then come back to the transducer so that it knows exactly what depth and time to position that echo on the image so that we know what depth this structure's at, what depth this structure's at, and that's done by measuring the time it takes for this signal to make that round trip travel time. Most transducers that we're currently working with have multiple, we call the transducer that we hold in our hand the transducer, but it's really the scan head, but those terms are kind of used interchangeably. Again, the transducers are these elements that are housed within the probe, and most transducers have multiple elements. So when we apply the electrical voltage, the signal goes out into the body, it comes back to the transducer, it's converted into a radio frequency signal, and that happens very quickly, and all of these elements are pulsed in succession. Depending upon the type of transducer determines how the elements are pulsed. The key thing to remember is that there are different types of transducers that are specifically designed to utilize for different types of scanning. There are different frequencies of transducers that are based on the size of the patient. So whether I need to have a lot of energy to be able to penetrate deep, or am I looking at a superficial structure? And that when this happens, this pulse echo technique, that the transducer is only pulsing 1% of the time. So this is happening very, very rapidly. It actually is listening for that signal to come back the majority of the time that it's actually sending and receiving the sound wave. And that allows us to, when we scan, to scan in real time. So that when I move the transducer, everything moves with me rather than me moving the transducer quickly and the image moving in slow motion. You always want to be able to see the structure of interest as it truly is. Now, the other key thing to remember is that sound, as I mentioned, sound requires a medium to travel through. It doesn't travel well through air-filled structures. So even though in your textbooks when you read that the average speed of sound in soft tissue is 1540 meters per second, many of you may go on to take your ultrasound boards, and I can guarantee you that question will be given to you in a number of ways. The key thing to remember is that depending upon the density and stiffness of the structure that the sound wave interacts with, that is what impacts whether you see a bright white echo, a completely black echo, or medium gray shade of an echo somewhere in between the extremes of black and white. It also impacts whether you actually can get the sound wave to transmit to the organ of interest, depending upon whether it's air-filled. So as I mentioned, when we excite the transducer and the sound wave interacts with the body tissues and organs, it then interacts with the molecules that make up that particular structure. In air-filled structures, in this diagram, you can see that the little molecules are widely dispersed. So when the sound wave interacts with this molecule and energizes it, this molecule needs to bump into this one and this one into this one to actually have effective transmission. But because these molecules are so widely displaced, the energy, it fizzles out before it even gets to the next one, and that's why we see a big black shadow or a fuzzy shadow when sound interacts with air-filled structures, such as the lung and the bowel. Now, fluid-filled structures, you see that the molecules are a little bit more closely aligned, so when the sound wave interacts with them, that chain reaction occurs quicker, the sound is able to transmit through that structure easier, and we're able to effectively see that particular type of structure. And then in solid structures, those molecules are really jam-packed in there, and so that chain reaction occurs even quicker. So when we look at all the little changes in speed of sound in different structures, the lowest speed of sound is in air-filled structures. It's faster in fluid-filled structures, such as vascular structures, the gallbladder, filled with bile, and so forth. and then fastest through solid structures. So that particular concept right there is how the system determines what echo shade of gray you're going to see. And then depending upon what we're looking at, we have normal characteristics. So the first thing is going to be, we got to learn what normal is. What's a normal liver? What's a normal aorta? What's a normal kidney? What's normal vasculature look like? And then based on what you see on the image, if it's different, you automatically know that's not normal. You might not know exactly what it is at this point, but you'll know that now I need to look at my differentials that fall into this abnormal based upon what grayscale these structures have been assigned. Now there's many ways in which we can evaluate the information that comes back to the transducer. So there's a list of different ways of displaying that information. A mode is amplitude mode. It's just going to be a series of spikes. We don't utilize that now as much as we had in the past, but I will explain how the system utilizes this to be able to create the grayscale image. B mode means brightness mode. So there's terms that are used interchangeably. Some people will refer to the image that you're looking at as a grayscale image. Some will refer to it as a 2D image. Some refer to it as a B mode image, and then real-time imaging is another term. They all mean the same thing. It's just the grayscale image that we're looking at. And then M mode means motion mode. And that is another way of displaying the information, but instead of looking at it in 2 dimensions, we're only looking at the structures in 1 dimension. So let's take a look at this. So first of all, how is our grayscale image developed? So there's a couple of different concepts I'm going to kind of weave into this particular slide here. The first thing as we discussed was the speed of the sound, or the structure that the sound beam interacts with, whether it's air, fluid, or solid, is going to determine the strength of the returning signal that comes back to the transducer. The strength of the returning signal determines what shade of gray is going to be assigned to that structure, from the blackest black to the brightest white. So internally, what the system sees when you're scanning is a series of spikes that are at a specific depth in tissue. So on the right side here of this particular image, and all images will have centimeter markers on them so you know what depth that the structure is at. And then when we're scanning, a key thing to remember is that whatever structure your sound wave interacts with first, it displays first at the top of your monitor. So if I'm scanning on the anterior surface of the body, then this will be anterior and the bottom will be posterior. But let's say I'm coming around and I'm scanning from behind, then my sound wave is going to interact the posterior structure first, so this would then be posterior, and this would be anterior. So always have to think, what structure is my sound wave interacting with first, and how am I scanning? In this case, we're scanning, this is the carotid artery here. This gray tissue here is the thyroid. And then you see this tissue from skin surface all the way down to the carotid has varying degrees of echogenicity. Some are very bright and white, some are a little bit darker gray, and some are medium level grays. And then you see that the thyroid is like a medium level gray shade. So 3 different structures, 3 different echo appearances based upon the density and stiffness of the structure, the way that it's comprised. So when the sound wave interacts with this is muscle here, this is sternocleidomastoid muscle. So muscle kind of has a marbling appearance to it, kind of like a piece of steak. And so from here to the top wall of the carotid, all of this structure is all muscle, same density and stiffness. So when we look at the spikes, they're all the same peak, all the same height. Then the sound keeps traveling through, and it then interacts with the carotid artery, which is fluid-filled, a different density and stiffness. In fact, fluid-filled structures are very weak reflectors. So we often don't even see an echo, which is why it's assigned black. So when you look from the top wall of the carotid artery to the bottom, here, there's no spike because it's such a weak reflector. But then the sound wave continues traveling through, and it interacts with the back wall of the carotid. A different density and stiffness gives rise to a different spike, and then the structures beyond. So now what the system has is a series of spikes that are all different heights, and they're plotted at different depths. They're arising from different depths in tissue. Internally, the system only looks at these peak echoes and assigns it a gray shade based on the strength of the signal. So those that are strongest are going to be bright and white. Those are the weakest are black, and those that are somewhere in between get different shades of gray. So ultimately what happens is you end up with a grayscale image that shows the thyroid is a medium level gray shade all throughout because it's the same. The carotid artery fluid field is completely black, and our muscle, which has fascia planes and different density structures within it, has varying degrees of echogenicity. And by knowing what the normal characteristics are of these various types of structures, we can then determine is it normal or abnormal. Now you'll even notice that on this particular image, I have it as a dual screen. It's the same structure, but notice that the grayscale is a little bit different. This one is a little bit more contrasty, and this one is a little bit, has more gray shade, and it looks like the thyroid. If you look at this thyroid here compared to this one has more of a coarse appearance to it, where this one has more of a subtle appearance to it. And some people might even call it fuzzy. So the reason that these, even though it's the same image, the reason that they look different is because we've utilized a different grayscale map. Now, one of the things that you're going to do when you first start scanning is first you're going to pick the appropriate transducer, and then we're going to tell the machine what kind of exam we're going to do. When we tell the machine, we select the appropriate icon, let's say we're going to do a fast exam, it's already going to default your controls for an average size patient. So your gain settings will be adjusted appropriately for an average size patient. And another control that it adjusts is the grayscale assignments. And so if I'm doing a fast exam, that is going to involve looking at different structures, some solid, some fluid filled. Whereas if I'm doing a vascular access exam, I'm primarily looking at a fluid-filled structures. The more contrasty your image, the better edge detection you have. So typically the equipment manufacturers have set their grayscale settings when you tell it what you're going to do based upon that type of structure that you're going to be predominantly scanning. So if it's cardiac or vascular, you want to have really good edge detection. So you're going to see on those exams, you're going to have a little more contrasty image. But if you're going to be doing an abdominal or GYN or those type of exams, then you're going to see that you're going to have more shades of gray. It's going to look different. And the reason for that is the more shades of gray that we have, the better detail we have to see subtle changes in echogenicity within solid organs that may make the difference whether you say that's normal or abnormal. So just to drive that point home, that's why I have a picture of Abraham Lincoln here. If I were to plot this picture out and only use 2 shades of gray, black and white, bistable, and ask you to tell me what that picture is of, you would only be able to say that's a picture of somebody's face. But now I add in more shades of gray, some that are completely white, some completely black, but also varying shades of gray, medium and low level shades of gray, plotted at specific points, XY coordinates, to highlight the features of his face. You now have enough detail to say, not only is that a picture of somebody's face, but that's a picture of Abraham Lincoln. That's what grayscale does for us in ultrasound. The more shades of gray, better detail that you have when we refer to that as contrast resolution. So the thing to keep in mind in general, just as a basic fundamentals here, is that this is a blown up image of a kidney. So you can see it has wide changes of echogenicity. The central portion is usually more bright and white, and the medulla is more medium level gray echogenicity. And as we get into talking about more scan fundamentals, what you'll see is in the abdomen, we use the liver as our standard benchmark for normalcy. All other organs are compared to the liver to determine if they're normal or abnormal. So that is providing that the liver is normal. But that is, so when the liver is big, it occupies the entire right upper quadrant. So it's easy to be able to compare, and it's easy to adjust your gain controls to the liver as your standard before you go on. Then you know you got everything set appropriately. So remember that difference in grayscale is equivalent to changes in tissue compliance or the density and stiffness of the structure. We have 256 shades of gray, and the complete black, we use anechoic as our ultrasound term to describe black. If it's filled in with echoes but not completely solid, it's hypoechoic. And then as it gets to be bright and white, then we use either echogenic or hyperechoic to describe that. And the corresponding structures that would have anechoic or black will be water or blood. And then hypoechoic will be liver, and then fat and bone are your brighter, whiter structures. Now, M mode is another type of display that we can utilize as an adjunct to our two-dimensional imaging. So when we scan, we're looking at the structures in 2D. You're going to see that we're going to be recommending that you use at least 2 views to look at structures, particularly when you're looking for pathology. And by utilizing multiple views, we're essentially looking at the structure in 3 dimensions. Not all at one time, but by scanning in different scan planes. With M mode, we're only able to look at the structure in 1 dimension. So you might be thinking, why would we even use it? It gives us some extra information that we might not be able to see with 2 dimension, particularly when we're looking at the heart. And M mode was designed particularly for the heart. We do use it for other things as well now, but it was primarily developed to look at the heart. And the reason that it was developed is because M mode has a very fast frame rate. That's the rate at which we update our image. And because the heart is such a dynamic structure, we need to be able to evaluate that very quickly. And we refer to that as temporal resolution. And M mode has a very high frame rate or temporal resolution, so there's certain abnormalities that we can see better on M mode. So it complements what we see on 2D. We use it in selective times when we're questioning whether we have a pathological event going on. So in this example, when we're looking at the heart, we see a 2-dimensional image. This is the heart here. It's a parasternal long axis. This is the chest wall, and this is posterior. So this first fluid-filled area is the right ventricle. This is the interventricular septum that separates right and the large left ventricle, and the inferior lateral wall, formerly known as the posterior wall here. We also see other structures. We see the aortic root, the aortic cusp, left atrium, and the anterior and posterior mitral valve leaflets. In 2 dimensions, in a parasternal long axis, we see all of these structures in 1 view, and we can evaluate those accordingly. With M mode, we're going to pick an area that we want to slice through and only look at that one little slice at one time in 1 dimension. And so you select a button on your machine that's called M mode, and it's going to bring up a line, and you just use your trackball to place that line over the structure of interest. So in this example here, we see that the line is taking a slice, one slice through one segment of the right ventricle, the interventricular septum, the left ventricle, the tips of the anterior and posterior mitral leaflets, and the posterior wall. So when I look over at my M mode display, that's what I'm seeing. I'm seeing fluid-filled right ventricle, solid septum. The backdrop of the white is the left ventricle. This M shape is the anterior leaflet of the mitral valve, and then the posterior leaflet of the mitral valve and the posterior wall. So if I wanted to look for flutter on the leaflets of the mitral valve or so forth, I could see that very clearly here. Now if I wanted to look over here, I would have to take my trackball and move my line over further into the left ventricle or over to the aortic valve if I wanted to look over there. So it's just like having a loaf of bread. You're taking one little thin slice out and looking at it, and that's it. Where in 2 dimensions, you're seeing more structures at one time, and we use multiple views to be able to evaluate the entire structure. Now, as I mentioned, M mode was primarily developed to use in cardiac applications. And in fact, before we even had 2-dimensional imaging, it was the only way to look at the heart. You didn't have an image, you only had M mode. And then as technology changed, we got our 2D, and we kind of switched gears and used M mode as an adjunct to your 2 dimensions. Other structures, we can use it in the fetus. We can look at the fetal heart. We can look at fetal heart rate. We can look at fetal heart motion. And we can also use it in the lung to look for pneumothorax. So in this example here, this is with the transducer placed in the 2nd or 3rd intercostal space, mid-clavicular line. And what we see first would be chest muscle, right? So muscle, the chest muscle doesn't move, the pec muscle doesn't move. So all this from the top of the image to this bright white line that's moving here is muscle. And then we see a black streak and a black streak here. That's shadowing from the ribs. So when we look between the two ribs and we see this bright white line here, you see it shimmering back and forth. So that's what we should see in a normal lung. In a pneumothorax, that's not going to be moving. It's just going to be still. So we can typically see that with our 2D imaging. Some people have a little more shimmering of their pleural line than others. And in the beginning, it might be a little bit more difficult for you to appreciate that. So as an adjunct, you can use your M mode, and you can select your M mode button, drop your line right down through the middle of your pleural lining there, and you'll see that on the left here is normal. So structures that don't move, like the chest muscle, look like a barcode sign, and movement creates a fuzziness here. So this is the shimmering of the pleural line in a normal lung. No movement, movement. Whereas if this patient had a pneumothorax, then the pleural line's not going to be moving back and forth. Therefore, the entire field of view looks like a barcode. And we're going to be talking about this in more detail later on, but this is just kind of showing you the benefits of using M mode, a different type of display, to augment what you see in your two-dimensional imaging. All right, so we're going to get down to the nitty-gritty here with our scanning fundamentals. Many of you have already been scanning in some type of ultrasound, but some of you, this might be your first introduction to scanning, and so we want to make sure that we don't leave anybody out. The first thing is, how do I hold the probe or the scan head? The first thing is, you cannot be afraid to get yourself all gelled up, because you're going to have gel all over you, up to the armpits. You really want to hold your transducer like you would hold a pen. So when you write, you don't hold your pen like this to write, because you don't have any control over the pen. You hold it down like this. It's the same thing when you scan. You have to have control of your transducer. So you want to hold the transducer down close to the face that's in contact with the skin surface, and you can then anchor your hand with your pinky or one of your other fingers. But a lot of times when people first start scanning, they want to do this and hold the transducer way far away from the skin surface. They don't have any control, so you end up angling and sliding and unable to get the type of image that you'd like to get. The other thing people do when they first start scanning is they get the death grip on the transducer. They're so afraid of moving that they just hold it so tight. That doesn't do you any good either. You got to be relaxed, got to be able to move the transducer around freely and still maintain control. So you don't want to do either of those. The next thing to understand is how the sound wave comes out of the transducer, and what you do with the transducer is going to determine whether you rotate or you angle the transducer, determines where you're actually sending the sound beam. One of the next things I'm going to talk to you about is how the sound wave interacts with the structure of interest will determine whether you have a good quality image or not. So think of the sound wave, and your sound wave comes out like this. And so here's your transducer. So when I put the transducer on the skin surface, in this manner, the beam is slicing through the long axis of the body. If I want to get a cross-sectional view, then I have to rotate the transducer to slice across the body in a transverse scan plane. And then once I'm on the structure of interest, then I need to sweep through it. You're not just going to look at one slice through the structure. You got to make sure you look through the whole structure. So if I'm in longitudinal, I'm going to either angle, and that sweeps the beam side to side, or I'm going to slide. Same outcome, it's just a different way of getting it. And when I'm in transverse, I'm either going to slide up and down, or I can angle superior and inferior to slice through the organ, just like if you were doing a CT exam. Okay, so that is going to be key. So I'm going to show you a couple examples here. So to rotate the transducer, right now I'm in a sagittal or longitudinal view to, in this case, probably the aorta. And if I wanted to go transverse, then I'm going to rotate the transducer. So now the beam's slicing in transverse. Now notice that when I'm holding this up high so you can see, but notice that when I'm rotating the transducer, I'm using my fingers to twirl it, basically twirling the transducer. I'm not doing this. Don't use your arm and your body. You're going to get in all kinds of a contortion and hurt yourself. You just twirl it with your fingers. Now that was longitudinal. So now let's say I want to scan through that structure. I'm going to send the sound beam medial or lateral. So there's two ways, as I mentioned, of accomplishing that. I can angle the sound beam medial and lateral, or I can slide. Now notice when I choose the angle approach, my transducer stays right where I have it anchored, and I'm just sweeping the beam side to side. In transverse, if I want to sweep through, I'm going to angle superior and inferior, again noting that the transducer stays still. You're using the angulation maneuver to sweep through the structure. Now, that might work on some people and it might not work on other people, depending upon their body habitus. So we have to have an alternative approach. So we can do the slide or pan method, where we keep the transducer perpendicular to the structure and we slide medial and lateral. Now, of course, I'm making big movements just to show you the way that the transducer should be moved, but depending upon the type of exam you're doing will determine how big of movements that you do. So typically when we're doing some type of abdominal scanning or fast exam, you're making bigger movements. But when you're doing vascular access or cardiac, they're very, very minute movements, barely even noticeable to the field. So you have to just understand that different areas that you scan, there's different approaches. Now, if I was in transverse, notice I'm keeping the transducer perpendicular and I'm sliding inferior and then superior. You don't want to slide and angle at the same time. If I do that, instead of just taking slice, 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 like we should be taking little slices to the structures, if I slide and move, I'm just off, I'm totally out of it. So you don't want to do big angle and slide at the same time. It's one or the other. All right, and now this is probably the most important concept out of everything we're going to talk about. It impacts everything that you do, is the angle of incidence, or how you direct that sound beam into the structure of interest. The little physics term is the angle of incidence equals the angle of reflection. You don't have to really remember that, but that is the physics term. And if you go to take your boards at some point, you certainly will probably be asked that question. The thing to remember is that we get our best images when the sound wave interacts with the structure of interest at a 90-degree angle or perpendicular incidence. We'll be able to get an image if the sound beam just skims right over it at an oblique angle, but it will distort it in size, shape, and echogenicity. And that's why anybody can make anyone look like they have pathology if they're not paying attention to how they're directing the sound beam. And the other thing to keep in mind is when we're talking about longitudinal and transverse, we're talking about longitudinal and transverse to the organ of interest. We have longitudinal to the body, transverse to the body, but not all organs lie along the long axis of the body. Kidney is a perfect example. They lie oblique. So when I'm in a longitudinal scan plane to a kidney, my transducer is actually at an oblique angle to the body. So you have to think about how are the organs positioned in the body. So that helps you to know how to line up your transducer just to get started. So a lot of times what will happen is people will put the transducer down and they're not just in the general vicinity, they're not paying attention to how to rotate or manipulate the transducer to line it up to the long axis or the short axis of the structure, and they don't get the image they want because it's hitting the structure at an oblique angle. So then they go right for the controls and start changing all the controls around and going, I get frustrated, I can't get a good image. Don't work with the controls until you get the image on there in the appropriate size and shape. Then you do your controls. The only reason I would adjust a control before I get the image completely on there the way I want is if my depth isn't adjusted appropriately so I can't see the structure. So then you would adjust your depth. So to drive this, I got a couple examples just to drive this point home to you. The first thing I'm going to show you is an actual sound wave. There's specialized cameras that allow you to actually visualize a sound wave as it comes out of the transducer. This is a flat surface here. This is my scan head, and we're going to transmit the sound wave into the body. Now this sound wave is being directed perpendicular or 90 degrees to the structure, and you notice that we get a little tiny bit that transmits through. through transmission, but the majority of this signal goes right back to the transducer. That's what we want. We want all of that energy going back to the transducer. If I change the way that the sound wave interacts with the structure at an oblique angle, so now I've taken this flat structure, put it at an oblique angle to the transducer, look what happens. Almost all of your energy gets refracted away. Some is through transmission, but only a tiny little bit makes it back to the transducer. And when it does come back, it's coming back at an oblique angle, so my resulting image is going to be distorted. So let's say I'm looking at a vessel, and it's got a lot of echoes in it. So are the echoes because I have too much gain? Is it because there's a thrombus in the vessel? Or is it just because I'm not imaging appropriately? So you always got to think about what structure am I looking at, how does it lie in the body, and then manipulate your transducer to line up the sound beam accordingly. Now, clinically, how could that affect you? When you're doing any kind of ultrasound guided procedure, we're using the ultrasound so that we can be more confident in where we're placing the needle tip. So we want to see the tip, right? So this is a needle coming in, and we can see the needle, and probably that's the tip. But if I change my sound beam so that it interacts more perpendicular to the needle, look how much brighter and well-defined the shaft of the needle is, and I can much more confidently say that's the tip of the needle. So just in doing ultrasound guided procedures, this is really important that you make sure you line it up. All right, so the next thing is we talked about one of the factors is the transducer. So we want to make sure we're using the appropriate transducer for the type of application that we're doing. So what you guys are going to be working with a lot of different transducers because you're involved with doing a lot of different examinations. So the sector phased array transducer was primarily designed as a cardiac transducer. It has multiple elements within it. Typically there's about 64, but there could be more or less. And the key thing is that in these transducers, all of those elements are pulsed together but just slightly out of phase, which allows for the beam to be swept side to side and create a sector format. The reason that this transducer is best suited for cardiac is because of the way it's pulsed allows for us to have the highest frame rates. The heart's moving. We want to make sure we're seeing the heart moving as it truly is, not in slow motion. So that's why this transducer was developed for cardiac. The other thing is that with phased array transducers, they have a very small footprint on it. That is, the contact area of the transducer needs to fit in to the ribs, in between the rib spaces, and that's real tiny. Your other transducers have larger footprints on them, not as easy to see the heart, as well as the frame rates aren't going to be as high. So when we look at the type of image that we get with using a sector phased array, we see that it's sector format, and so the benefit of it is it has very high frame rates, so it's good for looking at moving structures. The downside of the sector phased array is if you look at the top of it, see how it comes into a very tight point, and all the structures that lie in the near field here are kind of bright and white and fuzzy, and that's because of the energy of the sound wave is it hitting fluid first, and we're getting artifact, that's called a ring down artifact that we're going to talk about in a minute, that obscures the structures of interest. And the field of view, the amount of structures that we can see are going to be less as compared to some of the other transducers because it comes up to a tight point. But the benefits outweigh the downside of it for looking at cardiac applications. Now, another type of transducer that you're going to be working with is called a linear array transducer. It's completely different. You see how it's got a rectangular footprint to it, and it's much larger. These do come in different apertures, so there's some that are larger and then some that have smaller contact area to them depending upon your primary reason for using this transducer. These transducers were specifically designed to look at superficial structures. So this is what you'll be working with when you're doing any ultrasound guided vascular access, soft tissue applications, foreign bodies, things like that. Now, when you look at the image on these types of transducers, the linear array, notice that it's not a sector format, it's actually a rectangular format. And the reason for that is the way that the sound wave is generated. In the previous example, I said that all the elements were pulsed together but just slightly out of phase. In the linear array transducer, the elements are all lined up and they're pulsed in groups of 4. So elements 1, 2, 3, 4 are pulsed, then they overlap, maybe 2, 3, 4, 5 are pulsed, and they're pulsed very quickly sequentially. And so since they're pulsed in a line, the sound beam can only be directed straight down. And that's why we have a rectangular image format as compared to a sector. But the benefit of that is we have excellent near-field resolution for looking at structures that are close to the skin surface, and we have a much wider field of view. So I can look, in this example, this is the patella. We're looking at the patella tendon here. If we're doing a central line access, this is our IJ, carotid here, muscle. We can look for foreign bodies. This happens to be a thyroid. Look at a little mass, any kind of vascular, anything that's superficial. The linear array transducers are going to be the best transducer for that. And then we finally also have our curvilinear, curved, or convex transducer, terms all used interchangeably. This is basically a hybrid transducer. They took a linear array transducer, curved the face of it so that you can get in between rib spaces a little bit easier and create a sector format, but with a larger field of view. So when you compare a curvilinear transducer to a sector, you see that the field of view in the near field is much larger as compared to the cardiac phased array, the sector phased array, and the image quality is much better because we're using kind of a hybrid technology. So the question I usually get is, our department only has 2 transducers. We have a linear array and we have a sector phased array, but we need to be able to do a FAST exam. We need to do some abdominal scanning. Can I use the cardiac transducer for abdomen? And the answer to that is yes. Of course you can. You just know that the limitations, you're not going to get as pretty of images as you do with a curvilinear. Your field of view in the near field is going to be smaller, so you'll have to scan around a little bit more. But you can certainly get a diagnostic image with the sector phased array in the abdomen. Now the next thing you want to make sure you do once you've selected the appropriate type of transducer for the exam that you're going to do is choose the appropriate frequency for the patient's size and shape, body habitus, because it's the frequency of the transducer that affects how far can I penetrate and what level of resolution or detail am I going to get. When the transducer is activated, the sound wave moves through the body in regions of high and low pressure. So if you remember, if you ever played with a slinky, the one thing that you know is that when you put it at the top of the stairway, it's in a compressed state and it's not moving. In order to get that slinky to move down the stairs, we have to apply energy. When we apply energy, it causes it to expand, and then it compresses back up, and then expands, and it goes down the stairway through a series of compressed and relaxed states. Sound waves move through the body in the same way. They're all compressed, we energize it, and then it causes it to expand, then it compresses and expands and travels through the body. This diagram here is depicting that, where we have our compressed state, then it's relaxed and then it's compressed. From one compression stage to the next is one wavelength. The wavelength is how far the sound wave can travel at any one point in time in the body. So in this example at the top, we're demonstrating a 5 megahertz transducer, and below is a 10 megahertz or a higher frequency transducer. So when we look at the distance that the sound wave covers from one compression stage to the next, you can see that it's a longer wavelength in the lower frequency as compared to the 10 megahertz. So what that tells us is that the lower the frequency, longer the wavelength, the deeper I can see into the body. A higher frequency transducer, shorter wavelength, I can't see as deep, but that sound wave is more concentrated over a smaller area, therefore I'm going to get better detail. So the rule of thumb is that you want to use the highest frequency transducer that gives you adequate penetration. You need to be able to see down to the last structure of primary interest. So what happens is you're typically using your highest frequencies with superficial structures and lower frequencies when you're dealing with deeper structures such as the liver, gallbladder, kidneys, and so forth. So I tell people just to keep in mind the 3 L's. Lower frequency equals longer penetration but less detail. You're going to have to give up something to get something else. Now, from a clinical perspective and how you operate your system, all of the transducers that we work with now are called wide bandwidth transducers, meaning that instead of only having one transducer that's one frequency, we can select a button on our machine to select 3 different frequencies using the same transducer. So each transducer has a wide range of frequencies, and it used to be that you could only choose your center frequency. You got what you got, and that's it. Now, you take your button and you either turn a knob or push a lever, and it will either give you a numerical value in megahertz, or it will give you a term that is the equivalent outcome of selecting that frequency. So some of you might be working with systems that when you change the frequency, it might say pen. Pen means penetration. That means you got to know that penetration is obtained by lowering the frequency, okay? Most systems will default, when you tell it what kind of exam you're going to do, will default at the center frequency, which is assuming that you have an average size patient, okay? So in this example, the frequencies that we can choose in this example are 8, 10, and 11. And so gen means general or average size patient. And then the other term that you might see is res, meaning resolution. And you got to know that if you want higher detail or higher resolution, you need a higher frequency transducer. So they're going to give you one or the other, the term or the actual number. Either way, you got to know the relationship of one to the other. So let's say I got a patient I'm going to do a fast exam on. I put the transducer down, pretty good sized patient. It's already defaulted at general. I can't see all the way down to the diaphragm. I'm immediately going to go to my frequency and I'm going to lower it to the whatever the lowest is on that for that transducer. Usually only have 3 options, okay? And then you'll be able to see that the image gets brighter and you'll be able to see down to the lowest structure. On contrast, if I have a little 90-year-old lady that has no body fat and I put the transducer on and gen, everything's going to be bright and white and blowing out at you, and you know that you need to increase your frequency to kind of tone it down a little bit so that you're not making any kind of mistakes. And then, so here's just a clinical example. This is a gallbladder, and this is skin surface. So you can see this is a very anterior gallbladder. It's close to the skin surface. So when I put my transducer down, using a 2 megahertz, the gallbladder, which should be completely fluid filled, no echoes within it, is filled with echoes. So for your question to yourself is this artifact or is this maybe sludge in the gallbladder? So the first thing I'm going to do is I'm going to recognize that that gallbladder is pretty close to the skin surface. So I might just be, overpowering it. So I'm going to increase my frequency to a 4 megahertz, and look how much it cleared out all those echoes just by increasing the frequency. And now the next thing I would do is there's a few little subtle ones right there. I would probably adjust my gain just a little bit. But in general, like that right away, just that one button tells you that's probably not sludge. That's artifact. So you can see the impact of changing frequency within your exam. When you select the icon for the type of exam you're going to do, these are the things that's going to preset. It's going to preset your grayscale map, your calculation packages, and your initial image settings. That is your gain controls for an average size patient. You are going to have to tweak that. It's just you got to put the transducer down, and that's going to determine what you end up doing. The things that you're going to tweak the most are your depth, your focus, and your gain. So let's start with depth. This is an image of the carotid and jugular vein, and this is the thyroid. So if I wanted to do an IJ, I can see the IJ here, but the image is cut off right at the back wall. When you're scanning, you want to be able to see around the structure of interest. So you want it to be a little bit deeper so that you can see what there might be lurking around in the general vicinity here. So I went from 1.8 to 4 centimeters. And now I can see the thyroid, the trachea, the carotid, the IJ, and I can look all around. And then if I want to tweak it a little bit more, I can. Depth is going to change from patient to patient. We're not going to be able to say, when you're doing an abdomen, put it at 21 centimeters. When you're doing a vascular access, put it at 2 centimeters. We're not going to be able to do that because everybody's body's different. So you're looking at it to look at the structures and to see, Can I see the structure large enough that I can actually make a decision? And am I able to see all the structures of interest? And that's what tells you what to increase or decrease. So in this example, it's way too deep. It's at 6 centimeters. And look how small my structure is. If I'm going to put a needle on a target, I don't want it to be that little, right? You want to have it big enough that you can actually see your target well. Once you've adjusted your depth and you have your image on there appropriate, the next thing is that you're setting your focus control. So when you look at an ultrasound sound beam as it comes out of the transducer, it doesn't just come out in a straight line. It comes out and then gradually diverges. And we call that the near field and the far field. The goal is that you want the structures of primary interest to fall within the region where the beam is the narrowest, because that gives us the best detail. It's going to be a lot more fuzzy and not as well defined if we're looking at structures here. Well, with the transducer technology we have today and the system technology, we're able to electronically focus the beam. And so what you want to do is look at your system, and on the side you'll see a little icon. This one looks like a little hourglass. Sometimes it'll look like an arrow. Every system has a little bit different way of displaying the focus control. And you're able to move that focus up and down through depth, and you also can have 1, 2, 3, or more focal zones. I usually work with 1 or 2 focal zones, because the more focal zones you have, it slows your frame rate down. So everything's going to start moving in slow motion. So the rule of thumb is to put your focal zone at the last structure of primary interest. Now this is the liver here, and this is the diaphragm. And so I want to make sure I can see clearly all the way down to the diaphragm when I'm looking at the liver. But notice that my focus is all the way up here. So I'm telling the machine, even though I can see all of this liver tissue, I'm telling the machine, I really am only interested in this first centimeter here. And so it focuses the beam here, which we can see is very well defined with small dots, but everything beyond it is falling into the area where the beam is spread out and causes it to have more fuzzy appearance. And where you really can appreciate it is in the diaphragm here. You see how it looks kind of zigzaggy and not well defined? But as soon as I move the focal zone all the way down to the bottom of the diaphragm, now all of my liver tissue looks the same and well defined. But even more importantly here, look at the difference of the diaphragm here as compared to here. It's nice, sharp, well-defined, not fuzzy and raggedy and jaggedy. So your focus setting, some machines give you the ability to change it, and some have it tied in with the depth. So if you don't see a focus control on your machine, it's because the equipment manufacturer was trying to make it simpler for you and made an assumption that if you have your depth set shallow, you're interested in a shallow structure, and it automatically ties that focus to come in shallow. But if you move your depth down deep, then it's thinking you want to look deep, and it moves the focus down deeper. So on some machines, you will have that tied in, and you won't have the ability to individually adjust it. And then the last controls that you're going to be working with are your gain controls. And we can refer to those as depth gain compensation, or DGC, or time gain compensation, TGC. What we're doing is affecting the reflected signal going back, and we're compensating for a loss of energy as the sound travels through the body. So the sound starts out really strong. The longer it travels in depth of tissue or over time, it's going to get weaker and weaker. So by the time it gets to the last structure of interest, it looks dark. So we want to give that a little bit of oomph, and we do so by adjusting those gain controls. Again, we don't adjust these gain controls till we have the structure on in proper size and shape. So some of you may have knobs. Those are easy. You turn to the right, you increase. You turn to the left, you decrease. Some of you may have these type of levers that are called slide pods. And depending upon the system that you have, you may have 4 or 5 slide pods, or you might have 9 or 10 slide pods. It just depends on the system. The key thing to remember is the slide pods that are at the top control the gain to the near field only, and then the ones on the bottom control the gain to the far field only, and the ones in the middle control the gain to the middle. So think of your image as in 3 segments: near, mid, and far field. And then when you look at your image, you're going to say to yourself, is this too bright, too dark, or just right? If it's just right, then you don't touch those controls that affect the gain to the near field. and same thing that you follow through with. So I'll give you a couple examples here. I'm using the liver here because in the abdomen, the liver is what we use as our benchmark for normal or abnormal. And so we usually will, when we're scanning in the abdomen, we'll usually look at the liver real quickly, adjust our gain to that, and move on, depending upon what you're doing. So notice that where the beam is the strongest in the near field, there's very little amplification. You slide them to the right to increase, to the left to decrease gain. But as we start getting into the midfield, notice that these levers are pushed out further. And then when we're all the way down here to the far field, they're all the way over to the right. So if I were to connect the dots, you'd have a little line that goes from left to right, increasing the gain. Now in this example, still liver, but now the near field is completely black. But I can see my mid and far field are about the same echogenicity. When you look at the levers, look at these top levers that affect the near field. They're all the way to the left saying, I don't want any amplification. And so this is dark. So I'm going to take all three of these and at the same time move them to the right until this level of gray brightness equals the mid and the far field. In this example, the near field's too dark, the midfield's just right, and the far field's too dark. So does this person have ascites? Does this person have cirrhosis and the liver is just too dense to penetrate? Or is it a gain situation? So I look over at my levers and sure enough, the near field ones are again too far to the left. So I'm going to take these two, move them to the right, and watch my image until this gray matches this level of gray. I'm not going to touch the midfield ones because that's what the liver should look like. I'm going to take these bottom ones and together at the same time, move them to the right and watch this black fill in until it's equal to the midfield. If I have these all the way pushed over to the right and I've cranked up my overall gain and I still can't penetrate the liver, that's a problem. Okay, you've got a really dense liver, you probably got someone with cirrhosis. Once I have set up the gain from near field to far field, so all the like structures look alike. This is all liver, so I want the liver to look entirely the same. That's when I adjust the overall gain. And you may not need to adjust it, but if you do, then you can increase it. You don't want to increase it too much, because if you increase it too much, then it over amplifies those echoes and distorts the image so that your diaphragm is much thicker and irregular, and all your whites and brights are too white and bright. So you want a nice kind of even, balanced image. And I'm going to end up here with three commonly seen artifacts. The first one is reverberation artifact. And this occurs, we always have reverberation artifacts, but depending upon whether you're looking at a solid structure or a fluid-filled structure determines whether you actually see it. When you're doing full bladder GYN scanning, you have a big fluid-filled structure that's what your sound wave is going to see first. And we said earlier that sound travels well through fluid-filled structures. So when we initially start scanning, we see this. The near field of the bladder is completely filled in with these lines, these concentric lines that are equidistant all the way across the field of view. Okay, so that's a reverberation artifact, and we're just seeing the echo because as it travels quickly through a fluid-filled structure, every time it makes that round-trip travel time, it plots a line. So the first thing that we can do is we can decrease our gain, and that will help to reduce the effects of the ring down artifact. We just see a little bit here and then maybe a little fuzz there, but for the most part we've gotten rid of it. But because this entire structure is filling up the entire field of view, that's probably the best we're going to get. So the key is you need to recognize it, that it is a reverberation artifact. It's commonly seen in fluid-filled structures that are close to the surface, skin surface, and you just have to work around it a little bit. This is the uterus and so forth. Now, here's another example, though, where I can get rid of it. This, again, is that familiar image of the thyroid, carotid, and jugular sternocleidomastoid muscle. Notice that we have echoes here in the near field of both the internal jugular and the carotid artery. That's a ring down artifact. Now, but it's surrounded by solid structures, so I can change my scan plane just ever so slightly to position these structures a little bit differently where the ring down artifact then falls into the solid structures. You might end up moving it back over, but at least you've now recognized that it is an artifact and it's not something within the vessel. The next type of commonly seen artifact is shadowing artifacts. There's different types of shadowing depending upon the structure that you're interacting with. We call them clean and dirty shadows and edge shadows. So let's start in the center here. We have the liver. This is the gallbladder, and here's a big calcific gallstone. So when sound interacts with bone, it attenuates the sound beam. That is, it loses energy, and it creates a big black shadow that we see being emanated from the calcific stone. And as you can see, it's dark, it's black, and it's well defined. So that's called a clean shadow. As compared to the type of shadowing we see with lung or bowel, this is in the abdomen, this is bowel gas. See how it's kind of fuzzy? So that's a different type of shadow, and usually we'll see that move with peristalsis. And then we also have what's referred to as edge shadows. Edge shadows occur because the sound wave is interacting with a curved structure. So when the sound wave comes down and it interacts with this vessel in a transverse scan plane, when it interacts with the curvature, it's no longer a 90-degree angle, so it creates a little black shadow. So this can be a useful artifact because it helps you to identify the borders of the lateral borders of the vessel. And then the other thing that we can see in this image, this is our next artifact, is called good through transmission. Notice that directly underneath the fluid-filled structure, it's bright and white, and it's housed within the edge shadows here. That is called good through transmission, or also another term is enhancement. And this is an artifact that helps us to decide, is this truly a fluid-filled structure or not? This happens to be a breast mass. Notice that it has internal echoes in it. But the fact that we have this good through transmission where it's nice and bright and white in between these two edge shadows tells us that that is a fluid-filled structure, and this is probably artifact here. So it can be useful in helping us to make a diagnosis. Typically, cysts are smooth walls, no internal echoes, and good through transmission. If you don't have all three of those criteria, it's not a simple cyst. And then the last artifact is beam section or slice thickness artifact. That occurs when you have a fluid-filled structure that's surrounded by solid structures such as the inferior vena cava. If I don't have my focal zone set appropriately and it's falling into the far field, then some of those reflectors can get merged together. And so in this example here, this is the inferior vena cava. It should be fluid-filled, meaning that it should be completely black. But we see a bunch of echoes here. So now the question is that thrombus, is that tumor invasion, or is that artifact? But my focal zone is way up here. I should have it down here, and when I do so, we magically cure the patient, okay? So all of these controls work together with your ability to understand how to direct the sound beam and manipulate the transducer. The key is that you really have to scan. The key factors that will contribute to a good quality diagnostic image are your transducer selection, use the highest frequency that provides adequate penetration, scan perpendicular to the structure of interest, and then set your depth and focal controls optimally, and then adjust your TGC score. There's nothing that can take the place of scanning. You have to go back and continue scanning whoever you can. The more you do, the quicker you're going to get at scanning, the more confident you're going to become at recognizing pathology versus normal findings.